I'm so happy that you've come to our inaugural event for the Bander Center for the 2017-2018 year. The Bander Center is an ethics center in St. Louis University that was started in 2007 from a generous donation by Stephen Bander. We actually serve the medical community. We educate students, residents, and physicians with regard to issues in medical business ethics. As part of this effort, we engage the community, the public. We ask questions about medical business ethics broadly construed. And so that's the Bander Center. I'm Jason Kuhn. I'm the executive director of the Bander Center. I'm a general surgeon. I have a faculty appointment at St. Louis University. And I started my tenure as the executive director this summer. And this is my inaugural event. So thank you very much. This is, thank you. My guest today is Ed Weisbart. So Ed, welcome. Ed is the chair of the Missouri chapter of Physicians for a National Health Program, which is a 30-year-old nonprofit research and education organization of more than 21,000 physicians, nurses, and other health professionals and students, and all others who support single-payer national health insurance. He's an assistant professor of clinical medicine at WashU. He volunteers in a variety of safety net clinics and other nonprofits across the St. Louis area and serves as vice president of the Consumers Council of Missouri. He received his medical degree from the University of Illinois, Chicago in 1979 and completed his family medicine residency and fellowship in family medicine education at Michigan State in 1982. He practiced family medicine at Rush Medical Center in Chicago for 20 years and served as the chief medical officer of Express Scripts from 2003 to 2010. Dr. Weisbart is well published in the literature as well. So Ed, I know, is one of the most articulate people when it comes to talking about single-payer healthcare, and I'm so happy to welcome you, Ed. Thank you for joining us today.
Thank you, Jason.
So I would say, first question I would like to ask you is just, why did you get into single-payer healthcare? What brought you to this? How did you get into single-payer healthcare advocacy?
Well, I started getting involved with it just when I began medical school, really. I mean, even before, it was part of the decision to go into medical school. I was thinking I needed to do something really profound to change the way healthcare was delivered, and it seemed like there were changes going on. I didn't see much actually happening directly with single payer, didn't know the words, but it sort of always resonated with me as a better model. And then as the movement began to gain traction, I jumped in, really. My main activity with single payer didn't begin until after I retired from Express Scripts, because they're really not a single payer advocacy organization, and found that I really had the time and the interest and the passion to start organizing the Missouri chapter, so we did.
There's something about your upbringing, your childhood, your person that makes you interested in single payer?
Sure, yeah. I guess I've just always been committed to the idea that if I see something wrong, I want to try to do what I can in my limited way to try to help fix it. My parents always sort of taught me that if you see somebody in pain or suffering or such, that you really should try to help them. That that's, I think, what brings a lot of us to medicine. Those of us who are physicians, healthcare is that. But it's pretty hard to stay involved in medicine and not pretty quickly start to see all the cracks in the system and all the places where people fall into the gaps. All the people who can't afford to get the health care that they need and who don't get their medications filled and who don't because they can't afford to, or who are making the trade-off of I wanted to go to the doctor but I couldn't because it would be too expensive.
Right.
Stories like that just lead you to think, that's really not them being irresponsible. That's actually them being responsible, and making these just dreadful decisions that we can do better than that. I'm thinking of somebody who I heard of secondhand in California who she had homeowners insurance, but she didn't have health insurance. And so she was having what she knew to be her second heart attack. And she knew that if she went to the hospital with her heart attack, without insurance, that was going to be $100,000 more than she could possibly afford. It would, possibly bankrupt her and her family, maybe make her 40-year-old son who has lived with her no longer have a home there to live in. And yet she also knew that she had homeowner's insurance, which would pay off the rest of her mortgage if she were to die.
Right, right.
And so she chose to go home and lay in bed so that if she lived, there was no bill, and if she died, the house was paid for. And her son figured out that's what she was doing because she looked pretty sick, and he dragged her to the hospital. And I don't know the end of the story except that she didn't die. So.
Right.
But those sorts of stories, any of us.
Wonder, could there be a better world? Could
Yes.
there be something different?
How could there not be a better world?
I know, yeah. I see what you mean. Let's switch gears a little bit. You've often articulated how single payer might benefit American businesses. All kinds, small business, large business. There's an argument for single payer healthcare from the business community, from the business perspective. This is unusual, right? You don't hear this in the media. Not hearing this out there. Can you tell us how you've come to have such a view and articulate that a little bit?
Sure. That argument has made sense for a long time, but it's gaining importance because of how much more expensive healthcare has been becoming. But the argument itself hasn't changed. The argument is basically pretty simple, that businesses, the leaders of businesses really want to focus on the thing that they're in business for, producing their product or whatever service it is, and providing the complexity of healthcare is really not their core business. So number one, it's a distraction, which requires a lot of internal resources. And then, number two, it's expensive. It's more expensive. Our system, as I think most folks have become to recognize, is roughly twice as expensive for healthcare than most other systems than any other system around the modern world. So 10 years ago, that was an annoying problem to businesses, but it wasn't top of mind because it still wasn't the biggest thing. But what we're seeing more and more is businesses are bearing up under the brunt of this and finding that healthcare, which had been number 6 or number 7 on their list of problems, is moving rapidly into the number 2 position for some businesses for whom this is the second biggest of their unmanageable expenses. And so we're seeing, that's one of the most exciting things for me, is that we're actually seeing business communities around the country starting to organize. So there's a large organization of tens of thousands, I think, businesses, medium, some very large, but mainly medium-sized businesses, tens of thousands as I understand it, called the American Sustainable Business Council. And over the last few months, they've branched into a subgroup called Business Leaders Transforming Healthcare, which now has, I think, more than 200 in just a few months, businesses that are focused on how do we make an agenda that really fixes the problem. And they've all come to the same conclusion, that they really don't want to be in the middle of the healthcare business. That's not why they open their business, and that they believe that they're wasting a lot of money on it, and they're starting to see healthcare as I've heard it described as a ball and chain around the ankle of their businesses, and making them lose on a global scale when they want to compete globally. That makes them lose on those competitions, and that's just increasingly untenable.
Yeah.
And so I think we're starting to see the business community begin to take a real leadership advocacy role in transitioning. Talking about.
Right. I like the answer, and I like the argument. I mean, so I want to put this into a little bit of a bigger context in your advocacy work. So that's like a utilitarian argument. You know what I mean? That you say this is a good, right? Because it's going to have this end result that people are going to want, right? But I mean, there are certain things about single-payer healthcare that kind of may be more something like, you might say, deontological. What do I mean by that? Well, it just comes from the substance of it. You know what I mean? It's good in and of itself. This is a good. So my next question is so is healthcare a human right?
Yeah, this is, I think, for a lot of folks, that's a really important question. Is it a human right? And I think a lot of folks who advocate for the Medicare for All strategy are passionate about that. They firmly believe, yes, it's a human right, anything you do that doesn't align with that means you're a cold-hearted, callous. And I'm not a student of ethics, and I don't know how to define some of these things. And I personally have a hard time figuring out what exactly is a human right, other than looking at like the United Nations Charter or whatever. Yeah. But when I've seen people say, well, if it's a human right, show me where it is in the Bible. Show me where it is in our founding documents as a nation, if it's a right. And I can point to life, liberty, and the pursuit of happiness, but that doesn't really kind of cut it. So I don't know if it's, I don't know what a human right, I don't know how to define that, I don't know, but what I do know is that I personally feel really a deep moral, personal obligation to help folks who are suffering, if I know that I can help them. And so, to me, if you see somebody suffering, you got to do something about it. Now, I've heard some people push back again and say, well, if it's a human right, I've heard physicians actually say to me, if it's a human right, does that mean that my patients can wake me up at 3 o'clock in the morning for any problem they want, that they have a right to me? And of course, in society, we have multiple rights that are always in contest against each other, and of course not, that's crazy. But for those kinds of reasons, I shy away from even the question of whether healthcare is a human right, and I glom onto my personal sense that it's I feel a moral obligation. And, I question anybody who doesn't feel that. Who can say that they don't feel a deep personal moral obligation to help people in need? And if you don't,
no one would say that.
I'm kind of through talking to you.
So outing people that way is kind of just doesn't serve your advocacy purposes. So we kind of talked about two arguments, you know what I mean? When you're out there advocating, which one is the most effective? I mean, what do people usually listen to and latch on to when you've changed minds, about this topic? What argument works?
Frankly, the one that is most compelling to most people who are not already along this line are the business arguments. Frankly, it's pretty easy to get folks to say, yeah, I like apple pie, I like motherhood, and I think everybody should have access to health care. Right. There are some people whom I have met and engaged in discussions that I had no idea that they disagreed with that last point, but they actually do, and unless you ask them, you won't find that out. There are some, but they're a tiny minority, and the vast majority of folks actually would say, yeah, I think every human being, certainly every American, deserves right to access to health care. But they quickly come back with the false narratives that we all have such easy access to about it being unaffordable, and we can't. Haven't you seen the national debt, and all these things? Yeah. The good news is that there's a ton of evidence about this. There's all the stuff on the TV machines, but if you actually do the primary research and look at the literature on this, there's more than 25 studies showing that yes, we can afford this. That at worst it's break even, and almost all the studies show no, it's not just break even, it's actually cheaper for the country. So when you start to make the business case, to me, that's what I've always found is the most persuasive. That's been the barrier for most people, and when they realize, when they realize that they can change things, when they realize that we can afford to do better, we actually can't afford not to change this. Yeah. That's the real argument.
Great. You're starting to get technical on me. So, let's talk about a technical issue, I think. Let's talk about this. I mean, so there are countries with single-payer health care out there. They're like living proof, right? Experiments. Some of these things, there are people waiting in these huge queues, right? There are long lines to get, a hip replacement. In the United States, you have, you need a hip replacement, you go to the doctor, surgeon's wait time, 7 weeks, something like that. You come in, get your hip replacement. Some countries with single payer, you're waiting 6 months. So are single payer and queues connected?
Not in the least. So number one, we have those queues here, right? If you can't afford health care here, you don't even get in line, let alone, waiting. But I think we all hear these anecdotes, these stories about people from Canada who have to wait. And Canada's the closest model to what I think makes the most sense for the United States. So having a problem in Canada is, I think, the most telling risk. So those are the stories we hear the most. So what's the data show? I mean, we know all these anecdotes, right? We all know these stories. I had somebody just what day is today? Today's Thursday, just Tuesday night in Kirksville, who was telling me that her uncle in Canada was waiting 18 months for hip replacement, and he had a heart attack and died because of the pain. And that she thought he wouldn't have died had he gotten his surgery sooner. And I'm thinking if he was at such high risk that killed him just waiting, you know, yeah, right, I think the surgery was probably a risky thing, and maybe waiting, maybe he lived longer, but I wouldn't go there. I didn't go there with her. But so we all have these anecdotes,
yeah,
and the anecdotes are driven in part because we all want to have an excuse, have an explanation for why my uncle died. So that anecdotes are hard to draw conclusions from. So you have to look at the data. So what does the data say? So in Canada, actually, the Commonwealth Fund has studied waiting lists around the world, and in Canada, the data says that 80% of Canadians wait less than 4 months for elective surgery. So emergent surgery, of course, you don't wait at all there. Right. Emergent anything there, of course, you don't wait. But these stories, you know, you would have the sense that 90% of Canadians are waiting 18 months for, you know,
that is the sense.
That's the sense. But the data says 80% of Canadians wait less than 4 months for elective surgery in Canada. And the other piece of this, of course, is that in Canada, because it's a one database system, a single payer system, you can actually go online in most places in Canada and find out, you know, I want orthopedic surgery, I want colorectal surgery, I want this, and I want Dr. Kodner or whomever I want. You know, you can pick your person and you can see that person's wait time. You can actually go online and see that data and go, okay, well, that's okay, I really want that doc. Or you can say, well, you know, I don't want to wait that long. Let's broaden the geography. Let me look within the next 100 miles from here. Or let's look in the other province. And you can get that data and make that decision of, you know, I'd like to get it done sooner, but I'm willing to travel a little bit to go see that doc who also has good quality metrics, but for some reason their waiting list is less. You can make those decisions. Here, you can't. I mean, there you can go to whichever one of those docs you want. Here, if I wanted to go see a doc in Indianapolis, it'd be out of network.
Who knows? Yeah,
that would be out of network. Even no matter what the waiting list data, I couldn't go there.
Yeah, yeah. So besides the fact about portability, I mean, of your, also have the issue of that maybe there's something about efficiency in there. That if you have the single payer, you have one system, and you can access data like that a little bit more easily.
Yep. The other piece about the waiting list is that it's true that Canada has an issue with waiting lists. Despite the data point that I just said, it is true that there is an issue. It's hard to find a Canadian who won't tell you an anecdote about themselves being unhappy about having to wait. But in their next breath, they will tell you, but I wouldn't make the trade because if I get leukemia, I don't have to sell my house.
Right.
You know, they'll make the trade. Plus, they do spend half of what we spend. Yeah. So I suspect if we cut our spending to half of what we spend, we would have major problems. And nobody's talking about that. There's nobody that I know, in our movement at least, who's talking about making a change that would reduce our spend. We want to slow down the rate of growth. Nobody's talking about cutting our spend by 50% and creating these problems. And it's a decision that Canadians have made. You know, Canadians could choose to spend more on healthcare and not have that issue, but they see it as not a life-threatening problem, more of an annoyance, and they don't want to have to deal with the increased cost.
Yeah, I love it. So cost does figure in some way. So if you enact single payer, I mean, what kind of costs? How do you decide? You know, is there something like a, you know, basic package, you know, for health? Start going there, you know.
Right. So there's a bill in Congress, actually, H.R. 676, that's been in Congress since 2003, that actually has already articulated what a basic package would look like. And this not being rocket science, this being sort of almost common sense and the common good, that list aligns pretty well with the lists that every country in the modern world has determined are essential. Yeah. It aligns pretty well with what the Affordable Care Act said are essential health benefits. It aligns pretty well with what Canada has determined has to be covered. So a starting point is pretty easy, and then with any system, the most critical thing is how is it governed going forward from that starting point. Yeah. So the bill that we're talking about, H.R. 676, has built into it a pretty robust governance process where you've got representation from physicians and patients and all these other organizations that really should have insight into it. And going forward, they would meet on a regular basis, a board of quality assurance essentially, and they would look at the benefit design and say, you know, this has to be changed. They would look at all the different pieces. And so setting it up, figuring out that's not the hard part. The hard part is making sure that you've got a pretty good representative and evidence-based governance process to keep it current.
Yeah. I like. Shall we take a moment and ask the audience to ask some questions? I think we have a pretty good showing for our first Bander event. Thank you so much for coming. We've started on a pathway of asking some technical questions and maybe some ethical questions, but I wonder if there's someone who might be able to offer a more substantial ethical question or a more substantial technical question. I wonder if, before you do, would you mind using the microphone? That would be great. While she's walking down to the mic, I would like to point out that we would like to have a Twitter flurry. I wonder, right? I look in the audience and I see people, you guys have Twitter. I know you have a Twitter account. If you could tweet using the hashtag Bander 2017 between now and around 6 o'clock at night. We're going to get those all together. We're going to look at how many shares, how many likes, and we're going to qualitatively assess them. And we're going to offer someone a prize. It's going to be like a Starbucks gift card for like $50. And so we really want you to tweet. Yeah, no, get in there and get going. Yeah, really do some tweets. So that I wanted to point out. Thank you for your question. Go ahead.
Hi, Cindy Bitter, emergency medicine physician. I also have a master's in bioethics. And the thing that we need to point out about places that have single payer is that healthcare is treated as a public good, not a way to generate profits for insurance companies, for-profit hospital corporations, and in some cases, individual physicians. So when you have the pharmaceuticals making 20+% profits on their drugs and really taking all of that profit out of the American population rather than distributing that burden more globally, as well as the amount of money that's going into the pockets of the insurance companies rather than towards actually providing health care, our numbers for healthcare spending are grossly inflated.
So something like the way you define healthcare. If you're defining it as a public good, this seems outrageous. Right? But, you know, does everybody define it that way? You know, I mean, I guess that's the question. Ed, do you think you could respond to that question a little bit?
Sure. I mean, you know, we've made this sort of decision on other things, right? We think that the public needs fire service. We think the public needs any of a variety, education. You know, we've decided that those things are protective to our society. You know, highways have enabled interstate commerce. You know, we've made a number of decisions like this before because we felt that this is what the public should have. It's a good role for government. It's in a sense part of the national defense. You know, the healthier we are and the more able we are to build up our industry by not diverting our resources to some small segment of industry that makes an unjust profit off of it, the more we're able to do that, the stronger the nation is. So from all those points of view, I think it's completely reasonable to define healthcare as a public good, aside from the obvious piece of people to be healthier. You know, healthier people are more able to make sensible decisions when you're not worried and in panic about your first order of Maslow's hierarchy of needs. You're never going to get to the fifth order of hierarchy of needs. You're going to be stuck down here. And, you know, so it helps society to have people have excellent access to healthcare. And, you know, as you just, sort of, mentioned, it's diverting all these. I saw somebody just a couple days ago who she has insurance, and I don't know what her illnesses are, but she said she has some illnesses that require her to spend, in addition to her insurance, $1,500 a month on medications. I don't know what that is. But her point of that was she hasn't been able to go shopping for clothing for about a year and a half. She hasn't bought the refrigerator that she thinks that her household could use. She hasn't done this. She hasn't done that. There's all of these things that she would prefer to be spending her hard-earned money. She works full-time. That she would prefer to be spending her money on that would actually stimulate refrigerator manufacturers and clothing industries and would stimulate the movies and would stimulate restaurants and whatever else. She would rather be spending her $1,500 a month in a way that's stimulative to the economy and personally enriching. Instead, no, it's going into these obscenely priced medications and financially unavailable medical care. So yeah, it's a public good.
I'm not disagreeing with you, by the way. I'm just pointing out that the people who make the rules in our society are perhaps have perverse motivations in that the pharma and healthcare insurance and for-profit hospitals and for-profit jails and many other things have lobbyists. And grandma with her hypertension and coronary disease doesn't.
Pharmaceutical industry, as I understand it, spends $450,000 per year per congressperson lobbying.
Right.
$450,000 per congressperson per year from that one industry. So, and we've set up this democracy wherein our legislators have to spend 4 hours a day raising funds to run for office. And so they have to be responsive to somebody who comes to them with a bucket of cash in one form or another. We wind up electing legislators. I'm kind of off the topic here a little bit.
We can go there.
Okay,
we
wind up electing legislators who are highly skilled at raising cash rather than electing legislators who are highly skilled at creating good legislation. I saw Al Gore made a statement a couple weeks ago that when he was first running for Congress in the 1970s, he didn't attend a single fundraiser. Didn't have to. There were others who did, but he didn't personally spend any time on this. And now that's our whole, and as a result of that, we have, and that is, to me, what you're talking about. That's the perverse decisions. That's how we wind up with the pharmaceutical industry owning our legislature. At $450,000 a year per congressperson, they own it. You know, that's how we wind up with the insurance industry owning it. And that's why it's hard to get to what actually the majority of Americans believe we need. You know, nobody wants, other than those small subgroups, the pharmaceutical and the drug and device manufacturers and the insurance industry, other than those groups, and I guess there's the occasional, you know, pretty strong ideologue who, you know, thinks, you know, social Darwinism to the nth degree. Other than those groups, most Americans want this to change. And the barrier to it is the way the legislature works.
Political. Let's go in that direction a little bit. You know, I would say there is kind of like the political problem is multi-level, right? So we're very focused on the political problem of getting something like Medicare for all enacted. Bill, you know, vote on. Start it up. Let's do that. It's a political problem, right? It's hard. Well, now say we've got it, right? And we're humming along, right? And you have this, you know, shared health governance, creation of that basic package of health goods, of stakeholders galore set up. I mean, do you think that political problem of that is too great? You know, if we can't get the thing passed, you know what I mean?
Right.
Now, when we're humming along, what's that going to look like?
So today we're talking about healthcare. Someplace elsewhere in town, there's probably another group having a very similar discussion about the environment, and there's probably another group having a very similar discussion about some other issue. And the point is, none of these things can be changed unless we fix the legislative process. Yeah. Unless we fix the corrupting influence of money on politics, none of these other things will change. We won't get to that really wonderful moment when I actually sort of imagined that. That was a very pleasant moment for me. We won't get there until we've fixed a big chunk of the electoral problem. Yeah. And if we do fix that and preserve that repair, you know, then yeah, I think we can manage this. Every other country can. Yeah. Every other modern country has figured out this solution, and I'm a proud patriot. I hate to say it, but I don't have to say it. I'm a proud patriot.
Right. But the experiment of it in the United States, you know, that's an experiment that's yet to be done. You know what I mean? I agree. I think we can do it. No, so that's great. I wonder if anybody can voice an ethical opposing view to single payer. I think Kimball, well, there are multiple. Dr. Codner, yeah, let's start that part of the discussion. I'm going to continue to be nice to my guests, but you don't have to.
Hi, I'm Kimball Cornu. I'm a palliative care physician, but I'm also faculty in healthcare ethics. I think, as you point out, the economic business argument is a popular one because, well, everybody would seem to benefit from that. But implicit in your comments, there's this assumption that we need to get the dollars figured out, and there's this value-neutral dimension to healthcare. Well, health is this overriding good that we should all have. As a physician, I think that it is a good, a common good. But as a pluralistic society, we don't have a common conception of what the good is. And so when you have things like, well, we're at a Catholic university, Planned Parenthood, Hobby Lobby and contraception. So when you have a single-payer system, there's a consolidation of authority. Central planning, I'm not going to get into Friedrich Hayek or anything like that, but the government, Medicare, and people that decide these things will say this is what the basic package should be. So, after Roe v. Wade, is that part of the package? Reproductive health, women's health. Well, there would be people in the country that would not like that, saying, well, our taxpayer dollars are supporting that. So how would you address that?
So the first part of my answer to that would be that we'll never come up with a perfect system, and no place ever does. Every place that puts in almost any kind of social change, a couple of years later, they slap their hands on their head and go, oh man, we didn't get that right, and they reiterate it. It's a constantly iterative process. So whatever we put in place won't be perfect, but it'll be better than we are today, and that's the arc we have to get onto. I would also say that there are some obvious areas where the country is in vigorous unresolved, if that's a way to put it. But those get all the spotlight and all the attention, that's a small part of what we're talking about, frankly. The overwhelming majority of what we're talking about in terms of healthcare, we all agree about it. There's a lot of focus on the controversy, which has to be addressed, and there needs to be a strategy for it, and I have a point of view, and you probably have a point of view, and we all do. Most countries have figured out how to get past the controversy and focus on the thing that we agree about. So, I'm not too worried about that being impossible. Plus, the implication is that today we don't have the problem of a society, and we do have that. Most people in the country don't have 25 insurance companies that they can pick from to customize the exact insurance product they want. Most have one or two. Most are offered, maybe they're offered one from their employer. So it's not like we would be going from a position of having almost unlimited choice about how you want your healthcare benefits designed to having one. We'd be going from typically one or two choices today, whose decisions are made basically primarily for the profit center of the insurance company. We'd be going from that set of governance and dynamics and incentives to a system where we would all have said, our elected officials would have come up with, here's the list of things that we think at a minimum you have to have. That doesn't mean you can't have more. There would be, in most countries that have this kind of a consistent approach, there still is actually a niche for the private insurance industry as a parallel to it. But that represents typically less than 5% of what that country spends on healthcare, so it's not a problem it's not a nut you have to solve. So what you would do is you would set up that and this is what the bill proposes, that here's what we think every American has to have the access to. This is what we think almost every American probably would agree is appropriate, and that's what's articulated in this bill. That's pretty much what's in the ACA and other things. Here's a set of benefits that everybody has to have. There's other stuff. Maybe you think if you're in the hospital, you should only have a private room. Maybe you think you should be having access to experimental or unproven therapies. Maybe you think you should have access to this or the other thing. And those things which don't have the evidence that are as compelling for the public good, you could buy a separate policy for that. But insurance companies would be precluded from selling policies that replicate what's in the core offering. That's the...
I feel like there's kind of a strand here with both questions. We live in this kind of liberal society, right, where people are very proud of their precious freedom, right? And so it's like paternalistic us to sit up here and go, everyone ought to spend their money on some kind of standard package of health care. It's almost like that's sort of the underpinning. And so, I don't know. I think that's the strongest argument against single payer.
So you could go further with that line of thinking, and you could say you have the right to totally opt out of this program. But if you sign this paper that says you have totally opted out of it, and you show up at the emergency room because you were in a motorcycle accident and your head has got a problem, or if you show up in the emergency room with a heart attack, I am not just giving you permission to not treat me, I am instructing you to not treat me.
Yeah.
So if you have that like tattooed on your arm or a paper that you carry around or you're registered in some database that says, oh, this is Bob, he said he doesn't ever want to be treated through the public means. Okay, but nobody would sign that because they want a free ride. They want to not have to pay into the program until the desperate moment when they need it. And that's not right. That's not right.
Ira.
So I want to know where Jason lives, that we live in a liberal society. I'll turn on television tonight and see if I can verify that. So I thought I understood some of this, but it's getting muddied, especially from a recent experience. I've looked at international organizations. Point
the mic towards here.
Did a presentation to show that of all the countries in the developed world, only the United States has private insurance even show up on the graph, much less cover a third of the cost of health care. And we are by far, as you said, Ed, the most expensive in the developed world. So I put this to one of the senior level hospital administrators who replied, until we come up with something to pay for social welfare like these other countries do in the world, can't compare our cost of health care to other countries in the world because we don't provide the other social services. Stuck on that. How do you separate this and the power? I've been appalled by the power of the insurance industry. My other question would have been, should we have a single payer system, what's going to happen to the private insurance industry? So if you can link those two impossible things.
Let me take the first part first, if I might, because I've heard that argument too, and I'm really a data. I really love facts, and not the alternative ones. I like the real ones.
We won't hold that against you too much.
So I've seen some countries where the social services spend is obviously much higher than it is here. And I thought, well, wouldn't it be interesting if you can, and there's a wide variation of how much different countries spend on social services. I thought, wouldn't that be interesting if you could do this graph of how much countries spend on healthcare? Here we are, and then here's countries that spend little, and then take the graph of how much countries spend on social services and see if you flip it upside down, do they fit together? I thought that would be really intriguing. That's not the case at all. That's not the case at all. From my read of the data, the variation in what countries spend on social services doesn't in any way correlate, that I've been able to figure out, it doesn't in any way correlate with the variation in what they spend. So that argues against that concern to me. On the other hand, yeah, we should spend a lot more on, that's part of what appeals to me so much about this model that we're proposing here, is that today, if you wanted to do something to improve the health of the country in some way, you'd probably have to work it through the insurance industry. And the insurance industry knows that they're going to have roughly 20% annual turnover in their membership. So an insurance company doesn't want to do something that today is going to influence the health of their population 5 years from now, because with 20% annual turnover in 2 or 3 years, most of their members, more than half of their members, will be different people. They'll have somebody will have changed their job, they'll have changed this, employer will have changed what they offer, they'll be different people. So if you try to do a public health program, and so often those programs take 5, 10, or 20 years to have a return, if you try to do that, if an insurance company tries to really do a good social service intervention today, they would be basically reducing the cost of healthcare for their competition, And that's what, when someone made the point about perverse incentives, that's a perverse incentive. So to me, this is the way to actually create a business case for the country to invest more heavily in those social services. So
If you look at the other developed countries in the world, I mean, I'm appalled just to walk on the streets and see we have homeless people sleeping on the street. Have you looked at the data from other developed countries in the world? Do the ones who have excellent social services, do they still have that? Or is that unique for us, the wealthiest country in the world?
Probably beyond my level of knowledge. Good question, but I can't.
Okay, how's it going? My name is Nathan. I work for the St. Louis Business Health Coalition. So it's an interesting place. Like, we are kind of like the meeting ground between all the health providers and large employers here in St. Louis. I'm also a student here in SLU. But so my question is kind of, I guess like the two sides of what we can do here with how do we pay for healthcare is like either you have a single payer system or you have a totally like free market system. And what we have is some sort of like perversion in the middle where there's all this money has totally demolished the free market that we have for protectionist reasons, for insurance companies, for pharmaceutical companies, different things like that have allowed these prices to kind of skyrocket. So it's kind of ruined what we potentially originally had, and that started way back like before like the introduction of Medicare and Medicaid. Well, Medicare, obviously. But I guess my kind of question is, by instilling a single payer system, wouldn't we ultimately be avoiding answering the tougher question that there is in the United States with a larger discussion on what is true like health and like the discussion about like there's a new discussion arising about bringing up a larger discussion about death, like the proper way to die, because like here in the United States we go by let's keep people alive as long as possible. I worked as the EMT here in St. Louis for the past 2 years as well, and I've seen a lot of dark sides of how like that kind of goes. We don't talk a lot about like palliative care and things like that. And then as well, we don't talk a lot about what it takes to achieve health and stay out of the hospital. And hospitals look at patients as revenue, and insurance companies look at them as expenses, and then employers look at them as expenses. So it's all these different players going on in the system, and I always feel like if we just go to a single payer system, we're not answering any of the tough questions of how do we become a healthier society, because so far what we've seen with Affordable Care Act, people don't utilize their primary care physicians any more than they used to. They go to the ER, which is higher expenses, and like that's what I'm doing research on currently. But what do you have to say, kind of like, do you feel like we're missing the true question that we need to answer by going to a single payer system?
Oh, there's a lot in that.
Yeah.
So to me, I always try to look at what's the linchpin, what's the fulcrum, where's the governance process at, and what does that lead to? How are the incentives aligned, and what are the consequences of altering the alignment? And today, all of the incentives align with the problems you were just alluding to. No capture, the 20% turnover number that I was alluding to. So today, our system drives towards that result. On the other hand, so I don't know that we have to figure out how to define the word health. I don't know that we have to figure out the answers to all of those pieces of it in order to all I'm talking about is changing the economics and the finances of how we structure the healthcare finance model. That's really all that I'm talking about, and then looking and seeing if you make this change, is it positive or negative for the health outcomes, and I think there's every reason to think it would be positive for health outcomes, so I'm pretty comfortable with that. Brought up the idea of a free market and whether that's part of the solution. We don't have that today, right? In my practice, when I had a practice, also likewise about 20% or so of my patients would, just like the insurance has 20% turnover, most physicians will find that they have roughly 20% turnover in their practice because of insurance changing and people coming in and out of networks. And so most physicians in practice are looking to optimize their payer mix. That's a common theme. If you want to have a viable, thriving practice and you're not in a large employed group, if you're at a large employed group, the large employed group is trying to optimize your payer mix. But if you're at a small group, you'll be focused personally on trying to optimize your payer mix. That's not how we want healthcare to work. We want healthcare to work as a free market on the delivery side. I want a patient to come see me not because their insurance changed and I was on the directory for their new insurance product. I want them to come see me because Dr. Kuhn recommended them to me or because their neighbors recommended them to me. I don't want them to leave me because their insurance changed. I want them to leave me because I did something that made them want to leave me. That's, to me, how a free market on the delivery side should work. It shouldn't be based upon whether I'm affordable or whether, that should not be the driver. So to me, this is the best way to unfetter the free market on the delivery side. On the insurance side, as I said, most people don't have that choice to begin with.
Second half of my question, insurance industry.
He wonders what would happen to the insurance industry if we go to a single payer system.
This really is an existential threat to the insurance industry. But frankly, it really is. There would be some, place for them to provide benefits outside of what the Medicare for All model would provide. There would be a niche for that. There would probably need to be some back shop functionality like a TPA or some claims paying functions. There would probably be some back shop industrial roles for it. But yeah, there wouldn't be, that's why they're against this tooth and nail. They haven't done a terribly good job of demonstrating true value for the huge expense. So the parallel question is, well, what happens to the employees in the insurance industry? Because there's lots of them. I don't have a count, but there's lots of them. What happens to them? And I know many. I can't say I know most because there's so many, but I know many, and the ones I know are typically really smarter than me, hardworking, compassionate, decent people who are really, really working to do their best, working long hours and working their best to do their best to help patients navigate our crazy system. So yeah, I too would not want to see them disrupted. So the bill we're talking about has built in that for the first 2 years after this were enacted, they would have income protection for up to $100,000 for 2 years. And that's probably a pretty good chunk of time because the turnover in those jobs is about 25% per year. So the kinds of jobs we're talking about have roughly 25% annual turnover. Means again, by 2 years, roughly half or more than half of them won't be in those jobs anyway. So number one, there's that kind of protection for them, and number two, other industries would take off. That's what's happened in other countries. There's companies in Canada who have their customer base in the United States and would rather relocate to the United States and reduce their shipping costs and get more rapid delivery to their customers, but they can't, because it would add millions of dollars to their overhead and go out of business. So there would be an explosion of new jobs in a very productive way from this.
Like that, you've made this distinction between single payer and free market delivery, or let's try to get into that a little bit. The difference between single payer and single delivery, right? Other countries we talk about, they're really, they've got universalized healthcare of one kind or another. It doesn't, maybe it's because the delivery system is linked. How does that? This gets pretty technical, but how do you differentiate a single payer system from a single delivery?
So I see healthcare systems around the world organized in three large buckets, and of course each one of those many small buckets within them. But my simple mind likes to organize it into three larger buckets. And one bucket that I would call almost the extreme model, because that's as far as you can take it. So to me, that makes it the extreme model. Called the National Health Service, and that's a single delivery system, and that's where the government directly employs the medical staff. The government owns has built and owns the brick and mortar of the hospitals and clinics. That, to my understanding, is literally the definition of socialism. Socialism defined as the government owning the means of production. So that would be socialized medicine. That's what Great Britain does. That's what we do at the Veterans Administration, essentially. That's, to me, an extreme model. It's actually not what I think would ever resonate very widely. Another extreme model, and I call it extreme because there's only one country in the world, so that's extreme, that sets up their healthcare this way, is our incredibly fragmented multi-payer model where we have thousands. Every organization has its own payer structure. So those are two extremes. But I think in the middle is a pretty conservative model. You don't have literally a government takeover of healthcare, but you have just the insurance piece. So that first version is called a national health service, government providing the health service, but in the middle is just national health insurance. Really only dealing with the insurance changes, and gosh knows we need to have a lot of attention to our delivery models as well, but really I'm only focused on the national health. That's not that at all. That, as I said, if you pull the insurance piece out of it, to my mind, unleashes the free market for the delivery side. That is Medicare.
That is Medicare. I agree. Yep, that's interesting. Let's get to a closing question. What's going on in legislation? But they added on, and they were talking about single-payer health care. And so it's in the news. They're talking about it. Summary, what's going on?
Sure. The one sentence would be that it's never had more traction than it does today. Politically or demographically, it's never been more supported. So there's a House piece and there's a Senate piece. Yeah. So, and then there's the state piece, and I promise you Missouri won't be the first state to do it. So don't have to probably explore that. So in the House, there's a bill called H.R. 676 that I've mentioned a few times, sponsored by John Conyers from Michigan, and Emanuel Cleaver from Missouri. When it was introduced by John Conyers in 2003, it had, I think, 38 co-sponsors, which is nice for a starting bill. And it gradually increased. The same bill came reintroduced every year, every session. And right before the ACA, it had gotten up to, I think, 80-some co-sponsors. Actually, the most popular piece of healthcare legislation, the ACA kicked in. And then the ACA happened, and of course, the people who were supporting the bill were much more focused on let's make right. The ACA work. Yeah. It was there, dropped to something around 60 co-sponsors. And then we had a pretty meaningful change. Politics last fall. Maybe you didn't know, maybe you noticed that. So we started at 38. We got up to someplace around 90. We dropped down to someplace around 60. Today there's 117 co-sponsors for the bill in the United States House of Representatives. It's never been anywhere near that high. It's now got more than half. It's got well more than half of the Democratic legislators in the House of Representatives. Have yet to acquire a single Republican in the House, but there's a lot of attention being focused on that. We're starting to break rank and talk about it in a supportive way, and I think all the issues we talked about today are nonpartisan, so I think we're going to break that. But so it's got huge traction in the House. The Senate has had some bills that haven't gotten a whole lot of traction, but we're thinking probably in about a week, in the Senate by Senator Sanders. Senator Warren has already declared that she's going to jump on as a co-sponsor.
Right.
There's been speculation about what's in the Senate piece, whether it's going to be exactly a parallel to what's in the House. We have some areas of variance. I've been hearing is that there's two. Talking about having more financial cost sharing on his bill than there is in the House. The House bill has 0 copays, 0 deductibles. The bill hasn't been released, so we don't really know that. And he's talking about public option until we got to that. bill hasn't been released, and there's been quite a bit of discussion directed towards him in whether any of the things I just said are going to be in the bill when he releases it. Will probably be more granular than the bill. The House is not granular enough to actually implement. So as it went through committee, you know, when it got traction, I'm sure it would get longer, but it's easy to read now. It's only 30 pages, double spaced. Everybody should go read HR 676.
Right
it's
now
easy.
before it's too long.
Right.
Right, exactly, something like that. Great. Can I give you a moment to talk about Physicians for National Health Program? Sure. Go ahead and plug that for 30 seconds. How do you find out more about that? And
so go to pnhp.org, or for Missouri, go to pnhpmo.org, Physicians for a National Health Program, Missouri, pnhpmo.org, or follow us on Facebook at Facebook/pnhpmo. That stuff. It's 31 years old, 30 years old, mainly physicians, but lots of medical students and lots of folks who really aren't involved in healthcare at all, and certainly all the other healthcare folks. And it's a single issue, volunteer, primarily I'm a volunteer, 501c3 nonprofit, nonpartisan group that is entirely focused on research, education, and advocacy for Medicare for all. And in Missouri, we decided that we also focus quite a bit on Medicaid expansion in our state. Out on that as a parallel issue. mo.org.
Great. Thanks a lot, Ed. That was great. I would just like to give you a little applause, and hopefully we can get around. Thank you so much, everybody. You know, the Bander Center has a scholarly function. We invite you to the Bander Center to participate with us. We're working on our accessibility currently. How do you access the Bander Center? For right now, you can talk to me. You can talk to Aaron Buchanan, who's sitting in this side in the back there, and Tony Mikulek, who's in the middle here. We're all faculty who have appointments in the Bander Center, and so we'd like to invite you to participate in our scholarly activities. You know, we do abstracts, we write papers, we do that sort of stuff. That said, we would like to invite you to follow us on Twitter at the Bander, at this Twitter address. We've tweeted all week to our 5 followers. This is new. So we just started the Twitter account, and so we're building the Twitter account, and so if everybody could please follow us on Twitter. You don't have to have followers to make an impact on Twitter. Use hashtags and other things, you know, so that's what we've been doing. But please follow us. Don't forget about the prize. You still have an hour to tweet. And I would like to do some thanks at this time point. So thanks to Aaron Buchanan and Tony Mikulek, who have massively brainstormed this with me. I'd like to thank my 3 medical students who are part of the Bander Center this year. It's Matt Gracka, David Starr, and Annie Seskleifer. Thank you. I would like to thank our graduate assistant, Gunnar O'Brien, and I would like to thank KETC Channel 9. The videography arm of that is videoing us tonight. Thank you very much. And that's the thanks to everybody who made this possible. Of course, a big thanks to you, Ed. And so, with no further ado, let's go out into the lobby and have a drink if you like, have something to eat, rub elbows. You never know who's here, who's sitting next to you. Talk to somebody you've never talked to before. See if you can engage them in a conversation, hopefully about this or something else, and see whether you can make some progress. All right. Thank you, everybody, for attending, and I'll see you outside. Thank you.